Okay, guys, so today we're going to be doing like a question review for MSI pathology and dermatopathology. So let's start with the first question. Does anyone want to read, or should I read for you guys? And read for everyone. So we have a 72-year-old woman brought to the emergency room for right hip pain 1 hour after she fell while walking around in her house. She has been unable
No,
to stand.
screen.
No,
Yeah.
the screen isn't showing.
Oh my God. Okay. Is it showing now? Sometimes Canva, I know, doesn't work when I put it in full screen.
Yeah, it's working like this.
خلاص, perfect. Present. So do you guys want to read, or should I go ahead and read for you all? I'll just continue to read. So we have a 72-year-old woman brought to the emergency room for right hip pain 1 hour after she fell while walking around in her house. She has been unable to stand or walk since the fall. Examination shows right groin tenderness. Range of motion on the right hip is limited by pain. The remainder of the examination shows no abnormalities. Acute blood count and serum creatinine concentration are within reference range. An X-ray of the hip shows a linear fracture of the right femoral knee. She's scheduled for surgery. Which of the following is most likely the underlying cause of the patient's fracture? Is it A, reduced osteoblastic activity, PTH, accelerated, or intermittent? It's in the clinical picture is pointing you towards A. And what do you guys think the diagnosis is anyways? Pros, that's it. All right. Basically, the main pathophysician that there is that sound disrupting a bit. Um, is it better now? Does this sound better? All right, perfect. Okay, so yes, you guys were correct. A is the right answer. Our patient over here does have osteoporosis, and the main pathophysiology behind osteoporosis is a reduced osteoblastic activity. Now, I know this lecture mainly covers pathology, but pathology and clinical correlation are really closely aligned. Even if you're a pathologist, you're not going to get a histological slide without getting a clinical picture in the background. So I wanted to ask you guys, what clinical picture would you expect to see someone who has osteoporosis? Like if someone walks in, what would you expect in their demographics, in their age, in their gender? Vertebral compression, correct. Correct. Old, that is true. Do you think it leans towards the gender? And if so, why? Postmenopausal, perfect, good job. Okay. Guys, Tara, sometimes they'll try to trick you and try to give you a picture of somebody who has vitamin D deficiency. That's wrong. That would be more so osteomalacia, okay? So typically somebody who has osteoporosis is a postmenopausal, correct? You guys are all right. It's a postmenopausal old Caucasian woman. So good job, guys. This is the second question. If anyone wants to read it, go ahead. Okay, I'll read it. So we have a 72-year-old woman brought to the emergency room because she has severe pain in her left hip after falling in the morning. She smoked a pack of cigarettes daily for 45 years. Her only medication is a vitamin D supplement. Physical examination shows that her left leg is externally rotated and appears shorter than the right leg. An X-ray of the pelvis shows a fracture of the neck of the left femur. Which of the following changes in bone architecture is most likely the underlying cause of this patient's symptoms? Is it overgrowth of the cortex and decreased bone marrow space, accumulation and resorption of cystic degeneration, loss of cortical mass and thinning trabeculae, or the position of lamellar bone interpursed with woven bone? Send your answers. I see that you guys are putting C. Why do you guys think it's C? And why not A? Like A is a pretty good differential. If you guys could tell me also, that's true. She does have osteoporosis features. Good job. Do you guys know what pathology they're describing in A? So C is the correct answer. I'll give that to you guys. And she does have osteoporosis, so that we would lose our cortex and we'd lose our trabecula as well. Um, but I want to know what you guys think of A and why it's not A and why you guys are voting for C. Yes, good job. Osteopetrosis. Do you guys know how osteopetrosis would present? It sounds really weird. Yes, good job. You guys are doing amazing. It sounds really weird. I remember when I was taking it, I'm like, what do you mean? Like they have more bone, but they're getting fractures. That is true. Weirdly enough, people with osteopetrosis do get more fractures. Do you guys know the diagnosis for D? I'm pretty sure it's included in the scope of your lectures, but D is Paget's, correct, Nasser? Correct. It's Paget's. Good job. All right, good job, guys. All of you got the correct answer. I'm so proud of you all. All the slides, I have some hidden slides. I feel like these questions were a little bit difficult, but it's up to you guys if you want to go through it. But these, you know what, let's go through it. Let's challenge ourselves. So we have a 42-year-old woman that comes to the physician with an acute severe pain in her lower back. She also complains of constipation and trouble sleeping recently. Menses occurs normally at 28-day intervals. Serum calcium level is 14, it's normal, and phosphorus is 1.5, normal. An X-ray of the lumbar spine shows compression of the L4 vertebral body and osteopenia. Which of the following most likely contributes to this patient's decrease in bone mineral density? Tell me what you guys think. Is it the increased ovarian production, increased calcitonin, increased interleukin-1, or decreased rank L? Guys, what does calcitonin do and what does rank L do? Why aren't we going for calcitonin? Why aren't we going for rank L? Good job, good job. Nasser, I'm liking your answer. So you guys are correct. The answer is interleukin-1, okay? And as Nasser said, increased calcitonin and decreased rank L, we're going to see decreased osteoclastic activity. And we know that osteoporosis is going to be caused by a decrease in ovarian estrogen production. And we don't have that in our patient. She's even premenopausal. So here I have a quick overview of osteoporosis, but you guys are doing a good job. I don't think we have to go through over it. But I just want to say some hints that they might give you in the clinical picture. It could either be primary, so as you guys described, it could be a postmenopausal woman, or it could be secondary. Secondary, the way that it's going to present, it could be someone with Cushing syndrome, so they're going to have like the moon faces, the abdominal striae, but also you could get someone who's taking medications. I see that they love to ask this question a lot. It could either be someone who's on corticosteroids or taking proton pump inhibitors. What you guys might see in MSI is someone who's taking corticosteroids. She might have rheumatoid arthritis and is all of a sudden coming in with fractures. She could be in her 40s, and they might not even like outright tell you that she's taking corticosteroids. They might give you the hint by saying she's having just rheumatoid arthritis or SLE. The answer would be due to medication. It would be a medication side effect, okay? Um, and yeah, you guys, we can diagnose it with a DEXA scan. But I think this is more clinical than it is patho. You guys did a good job. Okay, next question. We have a 26-year-old woman who has had malaise, arthralgias, myalgias for the past 2 months. On physical examination, there is no joint swelling or deformity. Laboratory studies show a serum creatinine level of 3.9. Renal biopsy shows proliferative glomerulonephritis. She received glucocorticoid therapy for the past 3 months. She now has left hip pain with movement. On physical examination, there is no swelling or deformity. A total replacement of the hip is performed, and gross examination of the section femoral head shows collapse of the articular cartilage over a pale wedge-shaped subchondral area. What is the most likely diagnosis? Is it avascular necrosis and chondroma? Okay, you guys are coming in quick with the answers. So why are you guys thinking it's avascular necrosis? And what in the clinical picture, apart from the pathology, which is the pale wedge-shaped subchondral area, what in the clinical, good job, Nasser, it's the corticosteroids. So corticosteroids can predispose not only to osteoporosis, but it can also predispose to avascular necrosis. I want to ask you guys, Tayyib, if we have a young patient, African American, they come in with cyclical pain in their hands, abdominal pain, what disease do they have? And what likely bone pathology could they, sickle cell? Good job, Nasser. And would you say that people with sickle cell are at increased risk of avascular necrosis? Yes, that is correct. So they have an increased risk of avascular necrosis. So you can either see it in someone older taking corticosteroids or someone younger who has sickle cell disease. So good job, you guys. You got the correct answer. I want to ask you as well, real quick. If we get avascular necrosis of the head of the femur, what artery is involved? The most common artery involved. I know this is not pathology, but it's like I'm trying to do a good review for everyone. What artery would be involved in avascular necrosis of the head of the femur? Good job. I see one good answer. Correct. Perfect, guys. You're doing great. You're doing amazing. So yeah, we have osteonecrosis or avascular necrosis. Oh, guys, for pathology, you know how some diseases sometimes have more than one name? This is low yield and it can be really frustrating, and I'm so sorry, but sometimes I'm gonna tell you guys to memorize all the names that they have because that's how they're gonna try to confuse you. They might put it's like the name of the scientist that it was named after, or they could put its actual scientific name. So if you guys want that A, it's like the difference between an A minus and an A. I would say like go the extra mile and memorize the name. I know it's a little bit tedious. It could be a little bit low yield. This like I remember that Dr. Oban did that to me when I did MSI. So I just want to give you guys the heads up. So you guys were correct. The most common artery is the medial femoral circumflex artery, and the most common location would be the head of the femur. So here we have our next question. We have a 71-year-old man with type 2 diabetes mellitus comes to the physician because of 9-month history of pain and stiffness in the right knee. He reports that the stiffness lasts approximately 10 minutes after waking up and the pain is worse in the evening. There is no history of trauma. He is 175 centimeters tall and weighs 102 kilograms. So he has an elevated BMI. Examination of the right knee shows tenderness in the anterior medial joint line and crepitus during knee movement. Laboratory studies show an erythrocyte sedimentation of 15, that's elevated, and a serum uric acid level of 6.9. Which of the following is the most likely finding in the right knee? Are we going to see periarticular osteopenia and pannus formation, loculated epiphyseal cyst, calcification of the cartilage and synovium, or osteophytes and narrowing of the joint space? What's your answer, guys? This question is a little bit difficult. I actually struggled when I was answering this one. So you know what, sometimes they like to ask a bit more difficult questions. I want you guys to be prepared for everything. Okay, I like that you guys are giving explanations. So for the people who said A, why did you guys pick A? And for the people, one person picked D and gave me a reason why they picked D. So I want to hear why you picked D and why you picked A. Oh, someone picked B. Why are we picking B? What's the diagnosis for D would be shown in osteoarthritis, correct? Degenerative disease. So guys, what's the diagnosis for A? When you see periarticular osteopenia and pannus formation, what disease? Rheumatoid arthritis. Good job. Rheumatoid arthritis, what population would you see it in? Older or younger, male or female? And typically, would it be bilateral or unilateral? Good job. It's bilateral. Females. Nasser, I wouldn't say necessarily older. It's an autoimmune disease. Typically, it presents in women from their 20s to their 40s. And I'm pretty sure it's Uban that says this, but like autoimmune diseases are like buy one, get one free, something like that. So typically, if they have one autoimmune disease, they'll have others. We'll get into that in a minute. But so it'll be around females in their 20, in between 20 to 40s. Correct. It's bilateral, it's symmetrical. Another thing, come on, about rheumatoid arthritis is that it's systemic. So not only are you guys going to see joint pain and joint illness, but they could have heart problems, they could have pulmonary problems. So consider that. Um, what's the diagnosis for D, sorry, for D? Yes, correct. It is extra-articular. I actually once saw a patient in real life with extra-articular, and she never came with joint pain, by the way. She came with the extra-articular manifestations. And because of her family history, we diagnosed her with RA. It was super cool. But guys, what is the diagnosis for D? Correct. D is osteoarthritis. And tell me, guys, real quick about the population of osteoarthritis. What people do you typically see with osteoarthritis? Is it unilateral or is it bilateral? Correct. It's older. Osteoarthritis is wear and tear. So, of course, who has the most wear and tear? It's going to be our older population. طيب. Would it be unilateral and bilateral? Unilateral. Good job. Good job. Okay, I saw someone say in the chat that it could be Charcot's joint. It's a very good guess that you're giving Charcot's joint, given that our patient has type 2 diabetes. However, I feel he would present younger if he had Charcot's joint, and they would probably give you an X-ray and show complete destruction of the knee. It wouldn't show osteophytes and narrowing of the joint space. So for those of you guys that answered D, you're correct. That the answer D is correct. This patient has osteoarthritis. And the hallmark finding of osteoarthritis is going to be osteophytes and narrowing of the joint space. Literally, guys, memorize that like that's your name, because they're going to keep asking you this in third year, fourth year, and fifth year. So take it with you, memorize it like it's your name. Okay. Next question. We have a 62-year-old woman that's coming to the physician because of a 6-month history of progressive pain and stiffness of the fingers on her right hand. The stiffness is worse at the end of the day. She recently retired after working for 28 years as a typist at a data entry firm. Physical examination shows swelling, joint line tenderness, and decreased range of motion of the first metacarpophalangeal joint. Okay, so you guys putting your answers already. And the distal interphalangeal joints of the right hand. Discrete, hard, mildly tender nodules are palpated over the second and fourth distal interphalangeal joints of the right hand. Good job. I like that you guys are putting the names. An X-ray of her hand was showing narrowing of the interphalangeal joint spaces with subchondral sclerosis and osteophytes. Which of the following is the most underlying mechanism of the patient's condition? Guys, both osteoarthritis and rheumatoid arthritis have presentation in our hand joint. How do we differentiate between the two when it comes to the hands only? Good job. I'm seeing people are putting correct. Good. So it could be based on the location. Whoever's saying unilateral and bilateral, that's correct. Osteoarthritis, we'd see it more a unilateral picture. But come on, osteoarthritis, we see it in the DIP and we see it in the metacarpophalangeal joint. Whereas rheumatoid arthritis is going to be in the PIP and mainly it's going to be bilateral. So good job, guys. This is C. How would A present? What is the diagnosis of A and how would A present? Good job, guys. All right, so you guys did amazing in osteoarthritis. Here I have some things that I just brought from the slide, but honestly, I don't think they're high yield, and I think you guys did a really good job at answering the questions, okay? So I'm gonna move on. We have a 42-year-old woman that comes to the physician because of a 10-month history of joint pain and stiffness in her wrists and fingers. The symptoms are worse in the morning and improve with activity. Physical examination shows swelling and warmth over the MCP and wrist joints of both hands. An X-ray of the hands are shown. Synovial biopsy of the affected joint would most likely show which of the following. Is it non-caseating granulomas, proliferation of granulation tissue, monosodium urate crystals, or calcium pyrophosphate crystals? This question was also a little bit more difficult, but again, I want you guys to be prepared for anything and everything. So I see the first answer. Why do you think it's B? Correct. Good job. But can you tell me the difference between can you tell me the difference between C and D? Which is a condition of C, which is a condition of D? Correct. Okay, Simin, why don't you know the answer? Are you confused between two answers? Honestly, give a guess. Even if it's wrong, make the mistakes now, and you'll never forget it the day of the exam. I'm glad that you do know the diagnosis because sometimes that's the hardest part. But why are you confused, Simin? You guys are answering really well, mashallah. I'm so proud of you guys.
Why do we
Okay,
have the proliferation of granulation tissue in rheumatoid arthritis?
okay, so rheumatoid arthritis is an autoimmune disorder, as I said, and it basically puts your body in a chronic inflammatory state. It puts your body in a state of chronic inflammation. So granulation tissue, as you know, is how your body heals wounds. No matter where the wound is, every single system, when it's been injured, it gets healed via granulation tissue. So given that it's an autoimmune disorder, it's your body attacking itself, it's your body degenerating itself, but obviously it has to reheal it, and it heals it with the proliferation of granulation tissue. MSA development, Panis formation is correct, but that's not the only sign that you would see of rheumatoid arthritis. Also, if you find a question like this in the exam that you think is difficult, you can also rule out all of the answers. So no, it's obviously not non-caseating granulomas, that's in sarcoidosis. And monosodium urate crystals and calcium pyrophosphate crystals, that's going to be seen, as you guys said, in gout and pseudogout. So you would see that in a male, you would see he'd have the large big toe, the swollen red big toe, history of drinking alcohol or eating purine-rich foods, but you can also cross out and get to the right answer. But I hope I answered your question properly. But it's good that you knew the diagnosis. Okay. We have a 68-year-old man that comes to the office with a difficulty in performing normal day-to-day activities with his hands. He has pain in his fingers, wrists, knees for many years and has been taking over-the-counter analgesics. The patient has been evaluated by doctors for joint problems in the past, but declined their treatment recommendations. He smoked cigarettes for 30 years. Vital signs are normal. Examination of the patient's hand are shown in the finding. Yeah. So what are we going to see if we do basically, what are we going to see? Calcific degeneration, cartilage thinning, and subchondral sclerosis, DNA, anti-DNA immune complex deposition, synovial Panis formation, or uric acid crystal deposition. I like that you guys are giving the diagnosis. That's great. What are these findings in the hands called? C is SLE. Good job. Good job. How would SLE, since you're asking about it, tell me how SLE would present and why, obviously, this is not SLE. Good job. Good job. You guys are doing great. And طبعا, of course, like any other autoimmune disease, it's more common in women of childbearing age. So you guys got the right answer. It is synovial Panis formation. We have one more question over here. We have a 31-year-old woman coming to the physician for a 2-day history of low-grade intermittent fever, dyspnea, and chest pain that worsens with deep inspiration. Over the past 4 weeks, she had pain in her wrists and fingers of both hands. During this period, she also had difficulties working on her computer due to limited range of motion on her fingers, which tends to be more severe in the morning. Her temperature is 37.7. Physical examination shows a high-pitched scratching over the left sternal border. Further examination would reveal what? Is it a mutation in the HFE gene, decreased C3 component, Coxsackie virus, or increased anti-citrullinated peptide antibodies? Guys, what disease would we see be? What disease would be correct in? I'm pretty sure it's also included in MSI. Okay, to save time, you guys are correct. D is the correct answer. This is something that Dr. Uban stressed on his slides is the anti-citrullinated peptide proteins. Guys, even if the rheumatoid factor is positive, even if it was one of the options in the multiple choice, go with anti-citrullinated peptide proteins because rheumatoid factor is not specific whatsoever. It's positive in a lot of different autoimmune disorders, rheumatoid arthritis, SLE. The most specific one for rheumatoid arthritis is the anti-citrullinated peptide proteins. This was something that Dr. Oban stressed on the slides. Again, I took this all from his slide. Something that I felt was kind of important, it actually came on when I did my exam, and weirdly enough, no one was able to answer it, was the strongest risk factor. They literally straight up asked us which HLA is associated with rheumatoid arthritis, and they gave us all of the options. The best answer would be HLA, although both of these were in his slides. The best answer would be HLA DR4. There's a very cute mnemonic for this that's in the first aid book. It's the a room has 4 walls. I'm going to spell it out for you guys in the chat so you know what I mean. So if this question comes for you guys, you're going to get it right for sure. Okay. So decreased complement is actually going to be seen in SLE. All right, our next question. We have a 47-year-old woman complaining of ocular burning sensation with increased blurring of vision for the past 5 years. On physical examination, she has keratoconjunctivitis. She also adds that it's increasingly difficult to swallow crackers. A biopsy of the lips showed marked lymphocytic and plasma infiltrates in minor salivary glands. What is the likely diagnosis? Is it SLE, myasthenia gravis, dehydration, Sjogren's syndrome, or rheumatoid arthritis? Nasser, why did you change your answer? Actually, wait, no, sorry, I misread. Oh, I must say I love the I love the mnemonic. So a drone with 4 propellers and 1 camera. Brilliant. So I see some people saying D and I see some people saying E. Why are we saying D? Why are we saying E? What is making you guys think of Sjogren's syndrome? Xerostomia. Good job. Good job. I saw someone answer E. Why would it not be E, or why would it be E? Good job. The thing is, Nasser, she's not having any joint findings. She's having exclusively ocular findings and xerostomia. Yes, as I said, autoimmune disorders are buy one, get one free. You can typically see rheumatoid arthritis and Sjogren's syndrome together, but given that she has exclusively xerostomia and keratoconjunctivitis, keep it very, very simple. Go with Sjogren's syndrome. If she had this and if she had joint pain and everything, then we would put rheumatoid arthritis. Plus, guys, as you can see, they could also possibly give you a clinical picture of Sjogren's syndrome and then give you different biopsy results. I want you guys to know So you guys whoever answered D, you're correct. And I want you guys to know that they might give you the biopsy. So you have to know that marked lymphocytic and plasma cell infiltrates in salivary glands are the key feature in the biopsy of Sjogren syndrome, okay? Yes, that's for rheumatoid arthritis. HLA-DR1 and HLA-DR4 are for rheumatoid arthritis. If you had to pick between HLA-DR1 and HLA-DR4, pick HLA-DR4. This lecture was one of Dr. Uban's pathology lectures. So again, Sjogren syndrome, autoimmune destruction of lacrimal and salivary glands. You guys did a good job. I think they wouldn't only give you a picture of the biopsy without giving clinical correlation, because honestly, this biopsy doesn't have any hallmark findings that would be very obvious to a student, okay? Next question, we have a 23-year-old woman that comes to the physician because she's embarrassed about the appearance of her nails. She has no history of serious illness and takes no medications. She appears well. A photograph of her nails is shown. Which of the following additional findings is most likely in this patient? Silvery plaques on extensor surfaces, pallor of the conjunctival mucosa, erosion of the dental enamels, or a cardiac murmur. This one's kind of direct recall. It's a little annoying, but I remember Dr. Uban was stressing a lot on this. Good job. I see you guys are answering A. A is the correct answer. Good job. Can you guys tell me why it's not B? And what finding would you see if it were B? So clubbing would be more in pulmonary diseases. B looks like iron deficiency anemia. And in iron deficiency anemia, typically they're going to see the finding called cholinekia. So it's going to look like a spoon shaped. So you guys were correct. I'm really happy that you guys were. Next question, we have a 35-year-old man that comes to the clinic with acute right knee pain and swelling. His symptoms have been present for a week and have moderately worsened over this period. The patient is able to bear weight but has significant pain when climbing the stairs or walking for extended distances. He attempted treatment with ibuprofen, which provided prompt but only temporary relief. Past medical history is unremarkable, though the patient was seen by his primary care provider for a diarrheal illness 2 weeks before the onset of his current symptoms. Examination shows a moderate-sized effusion at the right knee. Cultures of a joint aspirate reveal no bacteria. Which of the following is the most likely associated with this patient's joint symptoms? Is it a C1 inhibitor deficiency, high titers of anti-streptolizin O, histocompatibility antigen with HLA-B27, or positive serum anti-nuclear antibodies? Guys, why are we thinking C? And what from our clinical picture here is making you think towards C? I like your answer. See, this is what I mean when sometimes they'll ask you between two different names. What's the second name of Reiter's arthritis? Good job. Guys, is there any hint in this clinical picture that you would put reactive arthritis over, let's say, ankylosing spondylitis or psoriatic arthritis? Diarrhea. Good job. Guys, how do you know it? You know it from the diarrhea. So reactive arthritis typically happens after, usually it's in males, and it's usually in males that are a little bit younger. So as we see here, our patient's 35 years old. It's, honestly, the pathophysiology is not like truly understood, but they have a theory that it's caused by eating and getting a diarrheal illness. So it could be a GI tract infection. Hatta it could also be an STI. It could also be caused by chlamydia by chlamydia. Sometimes they'll either have GI illness or they'll have a sexually transmitted disease. And then they'll, a couple of weeks later, they'll present with joint pain. Guys, can you list for me a few microbes? I know this is like a little bit, again, microbiology, but I want it to be a really thorough review. a few microbes that can cause reactive arthritis. So you guys are correct. It is C. Can you list for me other diseases that would have a positive HLA-B27? In total, there are 4. Good job. Good job. So far, I'm only seeing 2. There's 4 in total. Good job. 1 more to go. Yes, correct. Good job, MSA development. طب these HLA-B27, if we were to measure the rheumatoid factor, would they be positive or negative? Good. So far, I'm seeing one correct answer. Disease for the option B is completely unrelated. That's actually going to be rheumatic fever. So that would present with a sore throat. Typically, you would see it in children. So it would be sore throat, fever, skin rash. It's just a distractor, honestly. What can I repeat? What do you want me to repeat? The last point. Okay, I'll just open the slide. So we have our seronegative spondyloarthropathies. And my main question was, if you measured rheumatoid factor in this group of diseases, what would you see? And as MSA development, it would be negative. So there are 4 very important diseases that make up our seronegative spondyloarthropathies. It's PAIR, it's the psoriatic arthritis, ankylosing spondylitis, the IBD, so that's Crohn's disease and ulcerative colitis, and R, reactive arthritis. All of these are HLA-B27 positive and rheumatoid factor negative. Please, guys, don't forget it's more common in males, okay? This is an overall summary of all of them. As we saw in the previous question, the psoriatic arthritis causes nail changes, and you guys honestly did a great job. I feel like I don't have to go over this. If there's any questions at this point, please let me know right now. No questions? Should I move on to the next one? All right, perfect. You guys are doing amazing. Okay, we have a 72-year-old woman that comes to the physician because of right knee pain and difficulty of bearing weight in the right leg for 2 weeks. She underwent a right total knee replacement 10 weeks ago. She has type 2 diabetes and hypertension. Her hemoglobin A1C was 8.5 2 months ago. The patient's current medications included metformin, lisinopril, and aspirin. Her temperature is 38, pulse is 85, blood pressure is 148/108. Physical examination shows a right knee scar with an erythematous border. There is no drainage. Range of motion is limited by pain. There is tenderness to palpation over the right knee joint. She has an antalgic gait. Analysis of the fluid aspirate is most likely to show which of the following. This is a bit of a confusing question, but I know you guys are going to do great. So guys, what diagnosis do you think our patient has over here? She has fever, she has pain, she had recent surgery, okay? It seems like she has an infection. What do you guys think the diagnosis is? It's unilateral. Okay, so our patient does have septic arthritis. But did she have a knee replacement? It doesn't say anywhere in the question that she had a knee replacement. It doesn't say anywhere in the question that she has a prosthetic. So guys, the most common cause of septic arthritis is what microbe? Oh yeah, you're correct. But no, still, she doesn't. Okay, Simon, you're right. Staph aureus is the most common cause of septic arthritis. This was a difficult question, but it's an AMBOSS question, so you know how it can be tricky sometimes. So guys, you're correct. It's A. It is wrong. It's A. This is a little bit of a confusing question, but the answer is A. Keep it simple. Honestly, a lot of the times in uni, they're going to take questions and remove a lot of factors. So knowing them, they would probably remove the knee replacement part to make sure no one would get confused. But keep it simple. The most common cause of septic arthritis is always going to be Staph aureus. But you guys did a good job, and I like that you're thinking. We did jump the gun a little bit. But I'm glad that you guys gave me two different differentials. I'm really proud. You did a great job. Okay, so we have septic arthritis, guys. How is the most common way to get septic arthritis? The most common way one person can acquire septic arthritis. Good job. Good job. Just know that if it's a man over 35 years, less than 35 years, it's most likely gonorrheal, okay? I know this is not related to, what's it called? Patho, but yani, again, sometimes patho will give you a lot of hints in the clinical picture alone without needing the biopsy. Guys, I can't stress this enough. Know the joint aspiration. Please know the joint aspiration. For septic arthritis, they might try to confuse you with the WBCs. For septic arthritis, it's always in the 100,000s. It's always extremely, extremely high, okay? Inflammatory, sometimes you can see it up to 30,000, but just know, please don't pick septic arthritis if it's 30,000. Septic arthritis will always have incredibly high WBCs. In the lecture, it says over 50,000, so I use that as your cutoff point. And of course, it's going to be greenish, it's going to be cloudy, and we're going to have a lot of neutrophils, again, over 75%. I took this directly from Dr. Oban's lectures. These were his cutoff points. But if you guys want, you can use it as your reference ranges as well. Guys, another thing I really want to stress, Hatta, is the findings when we do a joint aspirate. Also, by the way, I see you guys are talking in the comments right now. I wouldn't worry about it. That was a really hard question that I took from AMBOSS. It was a little bit tricky, and you guys are worrying about something that's more like fourth year or fifth year. But like, don't worry, you did great. And I'm sure they're not going to ask a question that hard in the exam. The way that you guys are thinking is more than enough. So you're doing great. I'm reassuring you guys are doing great. I need to stress, I cannot stress enough that you guys need to know this like the back of your hand. Can you guys give me examples of degenerative diseases, inflammatory diseases, and we already discussed septic. So I want an example of degenerative and I want an example of inflammatory. And I want you guys had to note that, as you can see, again, this was took directly, I took a screenshot from Dr. Oban's lecture. The question was, give me an example of degenerative and an example of inflammatory. This is a prime example of that. Sometimes inflammatory could have high WBCs, but it's always less than 100,000. They could have high PMNs, but it's never over 75. But that's the best way to differentiate between the two. Even sometimes, by the way, clinically, differentiating between inflammatory and septic is super hard. But I literally cannot stress this enough. Please study the slide properly. Good job. You guys are answering perfectly. Our next question is a 47-year-old woman that comes to the physician because of a 1-month history of progressive weakness. She has had an increased difficulty climbing the stairs and standing from a seated position. She takes no medications. Neurologic examination shows weakness of the proximal muscles. Skin examination shows diffuse erythema of the upper back, posterior neck, and shoulders. A photograph of the patient's eye is shown. Antibodies against which of the following are most likely to be present in this patient? Is it myeloperoxidase, centromeres, me2 protein, or that protein? Guys, what is this finding called? Good job. I see one person gave the diagnosis. What diagnosis are you guys thinking? Correct. It is the heliotrope rash. Good job. So guys, you were right. It's the me2 protein. Let me know if I'm moving too fast when it comes to answering the questions, if you need more time to read the questions or whatnot. But you guys did a great job. It is Me2 protein. And guys, how can I differentiate between dermatomyositis and polymyositis clinically? What is the main difference between the two? Good job. Yes. It's literally in the name, like dermatomyositis, derma, skin. Wow. Thank you, medicine, for that one, honestly. You guys did a great job. So we have our inflammatory myopathies. We have our dermatomyositis, polymyositis. I want to stress this a little bit, the biopsy findings. So polymyositis, you're going to see endomysial inflammation with CD8 positive cells, okay? I don't think you need to know this without having a clinical picture. So typically how it would present would be a clinical picture, someone with proximal muscle weakness, difficulty brushing her hair or getting up from her chair. They would give you this picture and might put this as one of the options, okay? So please know, guys, that polymyositis is endomysial inflammation with CD8 positive cells. And I've seen this question around, I don't know how high yield it is or how not high yield it is, but I also found it on Dr. Oban's lecture, that all of the inflammatory myopathies will have a positive anti-Jo antibody, as you can see over here. They would have a positive anti-Jo antibody, which is an antibody against antihistidyl tRNA synthase. It sounds really low yield, but there are a few questions on it on AMBOSS and I believe on UWorld. And it was also on the slides. So guys, please be prepared for anything. I need you all to get that A. And as I said, you have dermatomyositis. But guys, quick question if you didn't see the slides. Is it polymyositis or dermatomyositis that's an increased risk of malignancy? One of them has an increased risk of malignancy. This might be too clinical or might be beyond your scope, but it's kind of interesting. Good job. Good job. I don't know if they talked about it in clinical, but sometimes they'll give you a picture, a clinical picture of someone who has dermatomyositis, and they're going to be, what would you do next? The best thing to do next would be to look for any malignancies, okay? You guys were correct. Dermatomyositis is linked to anti-Me2, as we said it, and the biopsy findings is perimysial inflammation with CD4 positive cells. So polymyositis, endomysial, CD8 positive, dermatomyositis, perimysial with CD4 positive. Again, it sounds a bit low yield, but like you never know what they're going to ask, you know? We have a 35-year-old man that has experienced increasing muscular weakness over the past 5 months. This weakness is most pronounced in the eyelids, causing him to have difficulty with vision by the end of the day. After a night's sleep, his symptoms have lessened. On physical examination, he is afebrile. No skin rashes are noted. Oh, I love your memory aid. I wish I thought of that. That was actually a really good idea. So after a night's sleep, his symptoms have lessened. On physical examination, he is afebrile. No skin rashes are noted. Muscle strength is initially 5 out of 5, but diminishes with repetitive movement. A CT scan of his chest shows thymic enlargement. Which of the following is most likely the mechanism for his muscle weakness? Is it A, antibody-mediated dysfunction of the neuromuscular junction, B, delayed hypersensitivity reaction, immune complex deposition, lysis of muscle cells by CD8 positive lymphocytes, or secretion of cytokines by activated macrophages? Guys, why are we thinking it's A? What in the clinical picture is making us answer A? Okay, that's a good one, but they might not all have thymic hyperplasia. Yes, good job. Good job. This might be a little too clinical, but I want to ask you guys anyways, what other findings other than the eyelid can we see in someone who has myasthenia gravis? Other than ptosis, what else can we expect to see? Good job. They could complain of diplopia secondary to ptosis. Good job. Hatta guys, they can have dysphagia. Remember, they have your respiratory muscles are muscles too at the end of the day, but they can have your throat muscles, so they can have dysphagia. They can have shortness of breath. So it's not only the eyes, okay? So you guys were correct. You did a great job. The correct answer is A. How can I differentiate, without looking at the slide, how can I differentiate between Lambert-Eaton and myasthenia gravis clinically? It's a one-liner. That's a good option, the Tensilin test. However, it's something more obvious, Hatta. Good job. You guys are doing great. For Lambert-Eaton, guys, it's, as you guys said, it's going to be against the voltage-gated calcium channels presynaptic. But the thing about Lambert-Eaton is that actually the weakness gets less with repetitive movement. So initially they start really weak, but then the more that you do the movement, the strength comes back. Again, just to help you guys remember, I had a patient one time. He came in with Lambert-Eaton syndrome. Initially, we tried to do his patellar reflex, nothing. The more times you hit his knee, eventually the reflex would come and it would come stronger. So it's literally clinically the opposite of myasthenia gravis. Myasthenia, the more that they use their muscle, it gets weaker. Lambert-Eaton, the more that they use the muscle, the stronger that it gets, okay? And please know that it's associated with thymoma and thymic hyperplasia, but don't rely on it because they might not give you that clinical picture, okay? Guys, what is the most common cause of bone cancer? Good job. Good job. I see some correct answers. The most common cause of bone cancer. Guys, I'm really proud of you. Whoever said metastasis is correct. The most common cause of bone cancer is usually from metastasis. More than primary bone cancer, the most common cause is metastasis. Please know this. Please know this, okay? They could give you a picture, a very vague picture of someone with bone cancer and ask you what the cause is. If, guys, my advice, if they give you a vague picture, always know that they're asking for the most common cause, okay? So the most common cause is metastasis. If, and the most common location that it's coming from, as you said, is breast. We have two kinds of bony lesions. We can have the osteolytic and osteoblastic. As you can see here, this clearly looks osteolytic because it looks lucent. The osteolytic bone lesions, most commonly, again, is caused by breast. The osteoblastic, guys, the second you hear osteoblastic, the answer is prostate cancer, like 99% of the time, okay? So this is an osteoblastic appearance. As you can see, it looks like bony deposition over here. And this is clearly, again, the osteolytic lesion, okay? So let's go on with our questions. We have a 27-year-old man that comes to the emergency department with progressive right knee swelling and pain. He has no history of trauma to the area. The patient has no other medical conditions and takes no medications. The X-ray shows a large lytic lesion involving the proximal tibia with extensive soft tissue swelling. After additional confirmatory testing, the patient undergoes a right-sided above the knee amputation. Histologic examination of the resected mass is shown in the exhibit. Which of the following is a likely diagnosis? Is it chondrosarcoma, Ewing sarcoma, metastatic adenocarcinoma, osteoid osteoma, or osteosarcoma? Again, the clinical picture here is kind of vague, but this is a key finding in the histology. Also, guys, for this lecture, for the bony tumors, I really, really, really recommend the sketchy video. There's two sketchy videos for the bone malignancies. I swear by them. I used them when I had MSI and I used them for my step 1. 10 out of 10, highly recommend. Guys, I want to ask you, for those of you who are answering osteosarcoma, is there anything in the clinical picture that makes you think about osteosarcoma, other than histology? I'll share the link with you at the end. but you should find it in the resources Dropbox under sketchy. Good job. Okay, guys, I'm really proud of you. The correct answer is E. The pic is a very high yield picture. That's why I wouldn't be surprised if they brought it as well. And osteosarcoma is extremely common. Yeah, different things to consider. It's the fact that he's a young male. Bony cancers are more common in male. The fact that it's in the proximal tibia, good job. Guys, other than the proximal tibia, where else can we find osteosarcoma? There's somewhere a bit more common in the jaw. Good job, Nasser. I will give an explanation now of the histopic. Guys, for osteosarcoma, it happens, it's a bimodal distribution, meaning it peaks in two different ages. It peaks in younger males and in older males. It's most commonly in males, okay? So when they're younger, what is the most likely cause? And when they're older, what is the most likely cause? So again, it's a bimodal distribution. In a man in his 20s or a boy that's 15, what would be the most likely cause? A man in his 50s or 60s, what would be his most likely cause? What do you guys mean by primary and secondary? Get extra specific, extra specific. Primary is de novo. Good job. I found this in Dr. Uban's lecture. It's associated with a specific gene mutation. It's pretty high yield, honestly. If you guys had to want to do your step one, this is like, they love to test about this gene mutation. Good job. Good job. There's another gene as well. Even more high yield. Okay, I'll show you what I got from Dr. Uban's lecture. The retinoblastoma gene. It's super high yield. So guys, osteosarcoma, for whoever was asking about the histology slide, osteosarcoma is a tumor of the osteoblasts. And as we know, osteoblast builds bone. So when it builds bone, it initially builds osteoids. And as you can see over here in the histology slide, this is our osteoid very clearly over here. Again, you can see it very clearly over here. This is the osteoid. There are the spindle-shaped cells, but I think the specific hallmark histology finding is the deposition of the osteoid. So I hope that answered your question. Another thing, I hope you guys didn't read it. Where is the most common location of metastasis of osteosarcoma? I know a lot of pathology doctors like to ask this as well. Good job. You guys are doing amazing. Guys, in someone who does an X-ray, and someone who does an X-ray and that they have osteosarcoma, what are two hallmark findings would you find in their X-ray? Good job. What's Codman's triangle and what's sunburst appearance? What is it? Good job. Guys, I really want to stress that if they're younger, please think about the retinoblastoma gene, okay? And if they're older, it could be possibly that they have an underlying diagnosis of Paget's disease, or they had radiation. Good job. You guys are doing amazing. But be aware, they might give you an X-ray. But again, they would probably give you guys the clinical feature as well. And I'm glad that you guys know as well what is the cause. I'm glad you guys know that this is lifting of the periosteum and that this is soft tissue invasion, because they could also, it's fair game for them to ask you that, honestly. All right, moving on. We have a 23-year-old male that has had pain in the area of his right knee for the past year. On physical examination, there is point tenderness in a 2-centimeter focal area just below the patella, laterally over the tibia. A radiograph of the right leg shows a 3-centimeter broad base projecting mass from the metaphyseal region of the upper tibia. The lesion is excised. The figure shows the gross appearance of the sectioned lesion, which is the most likely diagnosis. I see you guys are already putting your answers. Why are we thinking it's E? Is there anything specific that makes you think about E? Good job, Nasser. That's a very good catch, by the way. Is there anything in the histology slide that makes you think that it's E? Correct. Correct. So typically cartilage itself will look and appear blue. So as you can see here, this is the cartilage, okay? And so firstly, I want to tell you guys that you did a good job. You are right. Osteochondroma is the right answer. But the hallmark finding of osteochondroma is the fact that it has a cartilage cap. So I'm glad that you were able to reach to the diagnosis from the clinical picture, but know that osteochondroma, the most hallmark finding of the osteochondroma is going to be the cartilage cap, okay? So as you said, Nasser, over here, this is our blue cartilage, and this is our cartilage cap. This is how it would appear in an X-ray. Again, very fair game for them to give this to you. I took this from Dr. Oban's slide. There is a possibility that he could bring these options. This is honestly not very clear, but over here, this is the cartilage cap. And over here, this is the cartilage cap, okay? This is the hallmark finding, okay? Next question. Guys, I'll give you a minute to read this on your own. I just need to get a charger and come back. Once you've read it, send me your answers and tell me why as well, why you think your answer is correct. Okay, guys. I'm happy to see some answers. Why do you guys think it's a chondrocyte? Good job. So you guys are correct. You're doing amazing. It is a chondrocyte. Typically, any cartilage anywhere in the body would appear as such on histology. It's kind of like, this is honestly the kind of histology image that they could give without a clinical picture from how, in a way, obvious it is, okay? So we have chondrosarcomas. This is a malignant tumor of the cartilage. It most commonly occurs in the femur. And as we said, cartilage usually appears translucent. It appears bluish, and it has kind of a glistening appearance. As you can see, this is our chondrosarcoma over here. This is our chondrosarcoma over here. And this is the histology appearance. It kind of resembles this, you see? So it's very obviously cartilage. Good job, guys. Our next question is a 13-year-old previously healthy boy that has had pain in the right leg for the past for the past month. There is no history of trauma or recent illness. On physical examination. There is warmth, tenderness to palpation on the right lower thigh anteriorly. And the circumference of the right thigh is slightly larger than that of the left. A radiograph shows a 6 centimeter expansile mass on the diaphyseal region of the right lower femur that extends into the soft tissue and is covered by layers of reactive bone. A biopsy of the mass is done, and microscopic examination shows sheets of closely packed primitive cells with small uniform nuclei and only scant cytoplasm. Karyotypic analysis shows a 1122 translocation, which is the most likely diagnosis. I'm seeing you guys are saying B. Tell me about the clinical picture. Good. Correct. Correct MSA development. Is there something about the location of the mass that makes you also think a little bit more towards Ewing sarcoma? Age, correct. Good job. That is true. It most commonly occurs in the diaphysis, okay? It's most commonly covered by layers of reactive bone. You guys know how this is typically described. You know how these layers of that reactive bone are described histologically speaking. I have a bit of a silly mnemonic for this. Good job, MSA development. It's the onion-like skin appearance. So like how you know how onions smell bad? Ewing sarcoma. It's so silly, but again, it helps you remember it, especially when you have to remember so many different things. And correct, you guys, I like that you're highlighting the small blue cell appearance because that is a key histological feature of Ewing sarcoma. It's one of the only, بالعكس, it's the only bony tumor that has the appearance of the small blue cells. So if they say small blue cells, answer Ewing sarcoma. Good job. You guys are doing a really, really good job. So as we see, this is the appearance of the small blue cells. Either the doctor can give you a picture or can describe it, okay? Please know it. Over here, as we can see, it's invading the medullary cavity, and this is the onion skinning appearance. So these are the layers of the reactive bone. Please, guys, also do not forget of the 1122 translocation, which causes the EWS fusion. They might not ask about this since it's a bit more obvious, but please know about the translocation. As MSA development said, it does happen in the diaphysis, and weirdly enough, it's most common in Caucasian. So they might give you حتى the demographics, okay? Our next question. We have a 69-year-old man that comes to the physician with a 2-month history of severe right hip pain. The pain is worse at night. He has chronic headaches and back pain for which he takes vitamin D, calcium, and ibuprofen. Examination shows hip tenderness and mild sensorineural hearing loss. X-ray of the hip shows a radiolucent lesion in the ilium with a moth-eaten appearance and a wide transition zone. An aggressive periosteal reaction. Wide excision of the lesion is performed. A photomicrograph of the section is shown. Which of the following is the likely diagnosis? I'm gonna say development. I like how you're thinking. So we have our chondrosarcoma, Ewing sarcoma, giant cell tumor, metastatic carcinoma, or osteosarcoma. What's the answer, guys? Why are we thinking C? I'm gonna say development. I think your explanation is a 10 out of 10. It is more common in females, but doesn't mean that it doesn't happen in males. Also, again, given that this is pathology and I took this question from a pathology book, they want you mainly to focus on the histology slide because there's a hallmark, there's a pathognomic finding in this slide that can help you lead to your answer. I hope it's clear. Focus on the histology slide and tell me what you think the answer is. Guys, if the patient didn't have cancer, based on the clinical picture, what other disease would you possibly think about that's non-cancerous, based on his clinical picture? Based on his clinical picture of sensorineural hearing loss, moth-eaten appearance, the fact that he has pain worse at night, that he's a 69-year-old man, headaches, back pain. There's a specific disease that if you hear sensorineural hearing loss, you would diagnose it. It's a bone, it's related to bone. It happens to older men. Typically, they're going to complain that their hats don't fit them anymore. They're going to complain that they can't hear that well. I'm going to say you have the correct answer now. Period. Tell me why it would not be type 1 collagen deficiency. Would type 1 collagen deficiency present in a man that's 69 years old? Yeah. Tell me how type 1 collagen deficiency would present. I want clinical symptoms. I want age. I want everything. Good job. But sometimes blue sclera is really obvious. So they might not give it to you. Why do they have sensorineural hearing loss? Why do people with osteogenesis imperfecta have sensorineural hearing loss? Bonus question, what's the mode of inheritance for sensorineural hearing loss? Good job, MSA. It's actually, so our ear bones are also made of type 1 collagen, so it also affects the bones of the ears. So it's not necessarily a compression of the cranial nerves, but more so exactly as Nasser said, fracture of the inner bones of our ears. Again, guys, I don't know if you did good job, Nasser, correct? I don't know if you did genetics, but also tell me about the mode of inheritance. Simon, achondroplasia is the people who are really short. Typically, they're gonna be very, very short, and they're going to have the enlarged head. So you guys, you did an amazing job, by the way. The answer is actually giant cell tumor. Yes, it's more common in women, as Simon said, but the histology is very, very obvious. It's very clear, it's very obvious. Another hint is the moth-eaten appearance. So here I took these, I took these actually from Amboss because I think they were more clear than that of Dr. Oban's slide. But as you can see, its histological appearance is quite literally in its name, giant cell tumor, and that's a giant cell right there, okay? Simon, you're correct. It's more common in women, but that doesn't mean that it doesn't happen in men. Please, guys, know where all tumors most commonly arise from. The giant cell tumor happens in the epiphysis, and it can also happen over here in the distal radius. This is kind of like a hallmark finding, a hallmark picture. And please, please, please know that it's also called osteoclastoma. Don't only memorize that it's called giant cell tumor. They might give you osteoclastoma as an option, okay? Guys, you did a great job in MSI pathology. Now we're starting dermatopathology. I would know the location, honestly, to be safe. Guys, for MSI pathology, I highly, 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 highly recommend step 1 first aid. Even if you're not studying for step 1, it's a great study adjunct. And Dr. Oban honestly likes to focus on it because he's in charge of like your step 1 applications and whatnot. So I really cannot recommend any more a resource Then step 1, first aid, especially for MSI pathology. It gives an incredible review for everything. So please, guys, go through it, okay? Do you want to start dermatopathology now, or do you want to take like a 5-minute break? Khalas, guys, let's do the break. We'll be back at 4:40 to continue, okay? I just want to say also, you guys did an amazing job in MSI pathology. All right, so I'll see you guys in 5 minutes. Very short break. Apologies that it was a little bit short. And there was a lot of questions and a lot of discussion, but you guys are doing an amazing job. And I have no doubt that you guys are going to do amazing in the exam. Are you ready for dermatopathology? Okay, guys, let's get started. I hope everyone's back. So our first question, we have a 27-year-old woman that has areas of scaling skin over the past month. On physical examination, there are 1 to 3 centimeter light pink plaques covered with silvery scale on her arms and torso. A punch biopsy, one of the lesions examined microscopically showed keratinocyte nuclei retained within cells in the stratum corneum. Which of the following descriptive terms best applies to the microscopic finding? This sounds very low yield, but weirdly enough, it's pretty high yield, at least for uni exams. Good job, MSA development. Guys, what is your diagnosis of this patient? So far we have one person saying the diagnosis. Good job. Why do we think it's psoriasis? Is there anything specific that if you read, you're like, this is psoriasis, I know the answer for sure? Good job, Simin. Good job. Guys, where do you typically see these psoriasis plaques? Most common location in the body. Good job. Which disease would you see on the flexor surfaces? A rash on the flexor surface, what are you diagnosing this patient with? An itchy rash. Correct, it's eczema. A is not true because they're asking about the nuclei present within the stratum corneum. We'll go over all of it in a minute. Okay, guys, good job. It is parakeratosis. Here's a quick description of all of them. So acanthosis is the thickening of the epidermis. Okay. This keratosis is premature keratinization in the stratum granulosum. I want to say that your feelings are valid, and this might be a little bit annoying to learn, but for whatever reason, I know that Abrar likes asking these questions. Plus, once you know these terms, it's easier to understand the histopathology of the dermatological lesions, okay? So we have hyperkeratosis, we said thickening of the stratum corneum, and so the qualitative abnormality of keratin. So the stratum corneum is going to have poor quality of keratin. And then we have parakeratosis. We have nuclei present in the stratum corneum, which there should not be nuclei. But note that this is normal in mucosa. So on your skin, parakeratosis is abnormal, but in your mucosa, it's normal. And if you see parakeratosis, guys, again, 95% of the time, your answer is likely psoriasis. And lastly, we have spongiosis, which is intracellular edema of the epidermis. So over here, you can appreciate that there is spongiosis. It's really hard to appreciate over here the parakeratosis, but I would know and memorize the fact that it's the nuclei present in the stratum corneum. Guys, what are the layers of the skin from the epidermis down to the dermis? The first aid book has a really nice mnemonic for this. The layers of the epidermis, guys, from superficial all the way down to the deep. MSA development, I love that you know it. So, Simon, the one more is the spinosum. So as MSA development said, it's come, let's get sunburned. So corneum, lucidum, granulosum, spinosum, and the basale. It's such a cute mnemonic. It's honestly amazing. Nasser, I'm going to explain your question in a minute. Simon, I hope the mnemonic that MSA development sent would help you out. You'll never forget it. So guys, over here, I took this direct screenshots from Dr. Abrar's slides. It's up to you if you want to go through them, but honestly, I don't see that they need explanation. To me, they're just pure memorization, but it's up to you guys if you want to go through them together. So do you prefer to do this together, or would you guys prefer to go through this on your own? Not sponsored, but again, first aid, Yosemite Step 1 First Aid has an amazing summary of all of this that's super easy to understand. So please, guys, please go through it. Please go through it, okay? To save some time, I'm going to skip over this, but if you guys want to come back to this, we can. Nasser, to answer your question, dyskeratosis is premature keratinization within the cells. So it has nothing to do with the nuclei itself, but to do with the keratinization. So we have a 25-year-old woman that presents to the clinic with a 2-day history of an intensely itchy rash. She reports that the rash appears raised, red, swollen, that seem to come and go, typically lasting a few hours before resolving spontaneously. The rash is triggered after eating certain foods or scratching her skin. She denies fever, respiratory symptoms, or any recent illness. Her past medical history is unremarkable. Physical examination reveals erythematous lesions, edematous plaques with central pallor on her arms and trunk. The lesions are non-tender and blanch with pressure. Which of the following best describes the underlying pathology responsible for her symptoms? Is it edema of the epidermis, edema of the dermis, lymphocytic infiltration in the epidermis, spongiosis in the epidermis, or granulomatous inflammation of the dermis? Guys, what does our patient have over here? What's her diagnosis and why? Hives, good answer. Urticaria, good answer. Allergy, good job. What physical finding on her physical examination is making you think of hives? I saw one person put C in the answer. Why do we think C? Good job, Nasser. Why is it not C? I mean, she is having an allergy, that's correct, but it wouldn't cause a lymphocytic infiltration in the epidermis. She's having urticaria, she's having hives. Good job, Nasser, that's true. The epidermis is not involved in hives. It's strictly in the dermis. Granulomatous inflammation has nothing to do. You would see that if someone had a foreign body in their skin. So the correct answer, as you guys said, is B, edema in the dermis. I'm really proud that you guys know this from now because I only recently learned this when I was studying for my step one. So good job. Really, really proud of you guys. So again, guys, as Nasser said, no epidermal changes. It's only in the dermis. I hope that's clear. And yeah, we can talk about the mast cell, the IgE, but I feel like this is more to do with immunology. This is Abrar's lecture. I'm not sure which one exactly, but I can send it to you. Um, Please know that when mast cells degranulate, they release two different things, histamine and trypsin. Sometimes where they try to get you is they won't put histamine as an option. They'll put trypsin as an option, okay? As you guys can see over here, this is the the gross appearance of hives. Over here is the histological appearance. This is our epidermis, okay? From here to here is our epidermis. And طبعا, this is all our dermis, which is what's going to be affected in hives. And as you can see, there's edema. So you can see that the collagen is loosely spaced. You can see the gaps. I hope it's clear, the gaps. But that means that it's loosely spaced secondary to the edema, okay? We have a 2-year-old. Guys, was this clear? Can I move on to the next question? Okay, I'll take it as a sign to move to the next question. So we have a 2-year-old boy that was brought to the office by his mother due to a rash that started 3 days ago. A similar red itchy rash on the cheeks, trunk, and arms had occurred intermittently since infancy. The mother thought that the rashes were related to the consumption of certain foods, but elimination of cow's milk and fruit did not improve the rash. The patient had a few upper respiratory tract infections, but no major illnesses. Similar findings are observed on the cheeks and proximal upper extremities. The diaper area is clear and no mucosal lesions are present. This patient's condition is often associated with development of which of the following disorders? Is it celiac, extrinsic asthma, Langerhans cell histiocytosis, psoriatic arthritis, or ulcerative colitis? What's the answer, guys? This is a bit of a harder one because the picture in itself is not very clear. But if the picture is not clear, guys, please, please, please read the clinical because the clinical gives you strong hints. If you want, we can go over it together. Nasser, why would you say it's B? And period, why would you say it's E? R, why are we saying it's A? Simon, we'll go over it together now. I'm gonna say development. Why are we thinking it's B? Good job. Why do you think it's eczema? Good job. This is a bit of a difficult question. Correct, Nasser. It's not related to food because they found no difference when they changed his diet. He has a rash, guys. He has a rash that has been coming since he was an infant, since he was a little boy. The rash is red. The rash is itchy. The rash comes in the cheek, in the trunk, and in the arms. Okay? The cheek, the trunk, and the arms. And the patient tends to have upper respiratory tract infections. What are you guys thinking? Guys, I'll break down this question with you. So the correct answer is B, okay? Eczema, the highest yield presentation of eczema is to be located on the extensor surface, but it can happen on so many different locations. It can happen in the face, as we see over here. It happens in the cheeks. It happens in the trunk, as we can see in the picture, or it happens in the arms. As we know, it happens on the extensor surfaces of the arms. Another thing that points towards eczema in the clinical picture is that it's been happening intermittently since infancy. Okay, eczema comes and goes for the rest of their life. Unfortunately, they're going to have it from the day they're born until the day that they die. It's also related to asthma, okay? It's known as a triad of atopic disorders, okay? It's going to be eczema, asthma, and oh my God, I always forget this one. Eczema, asthma, and allergic rhinitis. I'll send it to you guys. Good job, Nasser. Thank you so much. Please know the triad, because sometimes, oh my God, guys, in my exam, I know it was a while ago, but they literally gave us a one-liner question of a boy who had a rash and a brother who had a cough. That's all they gave us, no other detail, and we had to get to the fact that the patient had asthma/eczema, okay? But please, guys, know that it's a triad. Atopic disorders come in a triad. Triad means three. Triad means three. I'll send it right now on the chat. And typically, everyone in the family has it, okay? They could be like, oh, he has a family history of a brother with asthma, without clearly telling you this patient has eczema. So consider it in consider it in someone who has a positive family history as well, okay? I hope it's a little bit more obvious. This was a difficult question, but honestly, you guys are doing great. You're thinking in the right direction. Now that we revised it, guys, what in this clinical picture is making us think that this is eczema? I want you to teach it back to me. What in this clinical picture is telling us that this is eczema, sorry. Simin, I hope it's a bit more clear for you that we went over it together. Good job. Itchy, correct. Correct. You guys are doing great. I'm going to move to the next questions so I don't take up too much of your time. But if you have any questions, if anything's not clear, at the end, I put my email and I put my WhatsApp. Guys, please feel free to reach out. I'm here to help you, okay? Guys, eczema, it can present in the cheeks. This is a way more obvious presentation. This is the presentation that we know and love. Itchiness on the extensor surface. This is kind of, I mean, it looks insane. I've never seen this in real life, but I found it on Dr. Abrar's slide, so I put it for you guys. So God forbid, if he does bring it on the exam, you guys are not going to be surprised. On histology, marked spongiosis, you can appreciate that here. But honestly, this is not like a very high yield telltale pathognomic sign. They would give you guys a clinical picture as well. I don't know if this is in or out of the scope of your level, but please know as well that it's a type 1 hypersensitivity reaction. If you guys are taking immuno, they love to ask these things, okay? Next question, we have a 47-year-old woman. She has a rash that's been bothering her for 20 years. So she has recurring skin lesions over her elbows, knees, scalp, and lumbosacral area. These lesions are silvery, salmon colored. There are 1 to 4 centimeter plaques with scaling. On physical examination, she has yellow-brown discoloration with pitting of the fingernail. She continues to have the same lesions. Which of the following is most likely to be seen on a biopsy? Is it a band-like upper dermal infiltrate of lymphocytes, epidermal spongiosis with dermal edema, epidermal thinning with hyperkeratosis and perikeratosis, focal keratinocyte apoptosis, or IgG deposited along the dermal epidermal junction? You guys are correct. I feel like this was a bit of an easy question, but I can't stress how high yield this is. So please know the histology of psoriasis like you know your name. I said it for a lot of things, but this is extremely high yield. Okay, guys? I'll talk about the histology in a minute as well. We'll do another question. This is a bit of an annoying question, but I know you guys are going to do good. We have a 44-year-old woman that developed skin lesions over her elbows and knees during the past year. The lesion started as 4 millimeter pustules with surrounding edema, but then evolved into 1 to 5 centimeter plaques that are covered with a silvery white scale. The lesions appear first in areas of local trauma, but exposure to sunlit areas causes the lesions to regress. A biopsy of one of the lesions shows thinning of the stratum granulosum with marked overlying pericytotic scale containing microabscesses. Which of the following risk factors is most likely to be associated with her skin disease? Again, extremely low yield, extremely annoying question. I found it on the slide though, and I found it on Robin's Pathology. You guys are doing great. Good job. Nasser, I'm waiting for your reply. Sorry that I'm coming for you like this. But I want to make sure everyone gets a chance to answer. Yalla, I'm waiting for you. This is directly from the slide, direct recall from Dr. Abar's slide. Good job. It is psoriasis, correct. And HLA-B27, not necessarily HLA-B27. Good job. Good job. It is D. It is D. I think this question is very low yield, but again, I found it on the slides and I found it on Robin. So you never know. I want you guys to be prepared for anything and everything. So guys, our psoriasis, as we know, salmon-colored plaques covered by silvery and white scales. This is all of the histology. It's a lot. Please, guys, know it. The Auspitz sign, can anyone tell me what this is without looking? Good job, MSA development. Does anyone know the histological cause of the Auspitz sign, though? Oh, good job, period. You guys are doing amazing. Good job. Yes, correct. It's the thinning of the epidermis. And then what happens when they itch their skin? They expose the dermis. But basically, when you see those red spots, that's just exposed dermis, okay? What is the microabscess, guys? What is a Monroe microabscess without looking? Good job. What cells are they made out of? I'll give you guys a hint. It's made out of an immune cell. Okay, so far only one person got it right. You guys are giving me the right answers in relation to the pathophysiology of psoriasis. But what cells aggregate to form our Monroe microabscesses? Simon, good answer. So far, Simon and MSA development got it correct. Guys, please know that the microabscesses are formed by our neutrophils. They aggregate in the epidermis, and they're going to form the microabscesses. This is extremely high yield for psoriasis. Nasser, you are correct, and I'm glad that you know that as a pathophysiology. This is a nice image of psoriasis. As we can see over here, these are the dilated capillaries. Okay, these are the rete ridges, all of these. Okay, and we can see that there is clubbing of the rete ridges. Again, I feel it's hard to give you guys this picture without giving you a clinical correlation. So also making sure you know the correlation. There's, as we can see over here, there's parakeratosis. I feel like it's a bit easier to appreciate it in this picture that we have the nuclei and the stratum corneum. Okay, please know this. This is just repeating what you guys said. Good job. So we have a 28-year-old man that comes to the physician because of a 3-month history of recurrent pruritic rash on his face and scalp. He reports that he has been using a new shaving cream once a week for the past 5 months. A year ago, he was diagnosed with HIV and is currently receiving triple therapy and antiretroviral therapy. He drinks several packs of beer weekly. Vital signs are within normal limits. A photograph of the rash is shown. A similar rash is seen near the hairline and the scalp. And greasy yellow scales are seen at the margins of the eyelids, which is the most likely diagnosis. Good job. Good job, guys. The correct answer is C. Guys, what are some of our patients' risk factors? I mean, I highlighted it, but tell me on your own. What are some of our patients' risk factors that can predispose him to seborrheic dermatitis? And tell me about the pathophysiology. What causes this? Good job, R. Good job, Simon. But there's a bit of a more obvious underlying cause. Yes, sebaceous gland is included in the pathophysiology. But what we all have sebaceous glands, but not all of us have seborrheic dermatitis. What directly causes it? Nasser, correct. But what causes inflammation? Is it infection? Is it injury? There's a specific microbe that predisposes to seborrheic dermatitis. An infection with this microbe gives you this appearance. Correct, Nasser, it is HIV. Only one person so far got the microbe correct. Guys, another question. What other clinical presentations are related to seborrheic dermatitis? Other clinical presentations other than this, where else would it present? Correct, MSA. How would it present in a baby? In a baby, guys. So in adults, it can either appear like this, or it can appear as dandruff, as Nasser said. In babies, it's something that they call cradle cap. So they'll be like newborns, and the mother is going to complain that the head of the baby is flaking. Okay, that's typically how you can see it present. Guys, please know it's overgrowth of yeast or fungi called Malaysia furfur. This is the name of it. Please know it's, and obviously it would affect people who are immunocompromised, okay? And it's going to attack and infect the sebaceous gland. This is the histological image. The keyword, sorry, what do you want me to repeat? In children. In children, it causes something called cradle cap. It's going to be most common in newborns. The mother is going to complain that the baby's head is, it's having, what's the word? Basically, it's shedding. I forgot the word. I said it like a minute ago and now I can't remember it. It's flaking, that's the word. So in adults, it's going to be dandruff. In babies, usually newborn, it's called cradle cap, okay? And again, know the keyword, guys, follicular lipping. This is how it appears. There could be a perivascular inflammatory infiltrate consisting of lymphocytes and neutrophils. I don't think that's very high yield. I think I would remember follicular lipping. Follicular lipping is going to be perikeratosis. We said that that's going to be presence of the nuclei in the stratum granulosum and neutrophils near the hair follicles. And it makes sense that it would be next to the hair follicles because it affects the sebaceous gland. And we know that the sebaceous gland and the hair follicles all make up a unit together. This is a good image, honestly, for you guys to know. Our next question, we have a previously healthy 46-year-old woman that comes to her physician because of an itchy rash on her legs. She has no trauma, insect bites, or travel. Her vital signs are within normal limits. Examination of her oral cavity shows a lace-like white lines on her buccal mucosa. And this is a photograph of her rash. A biopsy would show what? Would we see a decreased thickness of the stratum granulosum, inflammation of the subcutaneous adipose tissue, proliferation of atypical squamous cells, lymphocytes at the dermo-epidermal junction, or is it proliferation of the vascular endothelium? MSA, why do you think it's B? Guys, I can see why you think it's erythema nodosum, but she has an oral finding that's extremely hallmark finding of this disease. Simon, you're correct. Good job. The answer is actually D, guys. Think about the oral lesion. This is a very confusing question, but once you realize it, it's super obvious. Think about the oral lesion and think about the skin finding over here. It does look like erythema nodosum, but it's not. Erythema nodosum would not have an oral appearance. It's also itchy. Is erythema nodosum itchy? It's not itchy. Correct, MSA, correct, Nasser. Simon, I didn't see your answer, but I feel like you put the right answer. So guys, the answer is D. Okay. Is it obvious that it's LP? What do we call the oral lesion that she has? It has a name. I remember Dr. Abrar stressed on it a lot. What's the name of the oral lesion on her buccal mucosa? Because she has oral findings and she has an itchy purple rash on her legs. So the diagnosis is lichen planus. So this is the oral lesion that they're describing. Correct, Nasser. Good job. Good job. It's surprisingly pretty high yield. So please know that it comes with an oral lesion and with dermatological findings. Okay. The picture is confusing, but that's why you also have to focus on the clinical image as well. Even if you're a pathologist and you're receiving a histological slide, they always send it with clinical correlation, with a clinical background. You're never gonna, even if you're the best pathologist in the world, you're never gonna get an image only. You're gonna get what the patient is presenting it with. But even though the cases are pathological, please also focus on the clinical image. Okay. We'll do another question. I know this was a little bit of a difficult one, but I'm preparing you guys for everything and anything. The pick is not enough for you to come up with a diagnosis, honestly. They always have to give you a clinical correlation. Even now, me as a graduate, when I did my steps, I needed to have a clinical correlation with a picture. But if he gives you a pick, it's going to be super obvious. He's never going to give you anything difficult, okay? He knows we're not pathologists. Anyways, we have a 25-year-old woman coming to the office due to a 4-week history of a pruritic skin rash. Pruritic skin rash. The patient has no chronic medical conditions and takes no medication. Vital signs are normal. On examination, there are pink papules distributed symmetrically over the anterior surface of the shins and ankles. Shave biopsy reveals prominent hyperkeratosis along a thickened granular layer. In addition, there is band-like infiltrate of mononuclear cells, predominantly lymphocytes, and in the subadjacent superficial dermis that involves the overlying epidermis. The rete ridges are sharpened and have a sawtooth appearance. The basal layer of the epidermis is degenerated with scattered colloid bodies. Which of the following is the most likely diagnosis? Good job, guys. It's a bit more obvious now. It's a bit more obvious now. I know the previous question was a bit difficult, but again, you'll never forget Wickham's try ever again, inshallah. You guys are very much so correct. Sawtooth appearance is pathognomic. If you see sawtooth appearance, it's likely that you have the correct answer, okay? So let's talk about the histology a little bit. I'm not sure what colloid bodies are, but it might just be over detail. It might just be like extra detail that they're willing to give. I don't remember seeing the colloid bodies on the slides. So just focus on the sawtooth appearance and the mononuclear infiltrate, the band-like mononuclear infiltrate, okay? So yeah, guys, the civet cells are going to be the necrotic anucleated basal cells. A little bit low yield in my opinion, but you never know. Sawtooth appearance, extremely high yield. Lymphocytic infiltrate at the dermoepidermal junction, kaman, it's high yield. I would learn that I would memorize that if I could. Guys, without looking, what are the 6 P's of the lichen planus? Tell me about the 6 P's. It's a really, really nice mnemonic, and it helps you memorize it so much easier, and it becomes a bit more clinically obvious once you know the 6 P's. Good job, guys. Good job. Perfect. You guys are doing amazing. And don't forget the W, which is the Wickham's striae, please. Okay? We're moving on to our next question. We have a 54-year-old woman that comes to the physician because of painful blisters under her arms that appeared 3 days ago. She had a 2-month history of intermittent painful lesions in the mouth. Examination shows several erosions on the buccal mucosa and the lips. Examination of the trunk shows multiple flaccid blisters with a diameter approximately 2 centimeters in both armpits. Skin biopsy specimens obtained from the area show the lesions showed detachment of the keratinocytes within the stratum spinosum. This patient's condition is most likely caused by autoantibodies directed against which component of the following cell junctions? Is it the desmosomes? Is it the hemidesmosomes? Right, guys, what's the diagnosis here? Good job. Why is it PV? Why is it pemphigus vulgaris and not pemphigus bullus or bullus pemphigus? Why is it PV, guys? Good job, MSA, correct. Good job, Simon, correct. Good job, Nasser. Good job, R. Wait, guys, the blisters in pemphigus vulgaris, are they easy to rupture or hard to rupture, and why? Okay, period, good job. But why is it easy to rupture? Good job, R. Good job, period. Guys, what's the Nikolsky sign? I know this is a little bit clinical, but this is how we can also differentiate between pemphigus vulgaris and bullous pemphigus. What is Nikolsky sign? Good job. Amazing, guys. Good job. So is Nikolsky's sign positive in vulgaris or bullous pemphigus? Which one would you see a positive Nikolsky sign? Bonus question, not related at all, but what other diseases, not PV, that could cause a positive Nikolsky sign? If you guys don't know, it's fine. It's just like a fun little review for us. I'll skip it because it's not that important, okay? Anyways, you guys are correct. E is the correct answer. And we have another question. We have a 65-year-old man that developed pruritus followed by blistering skin lesions over the trunk, legs, and arms for the past month. On physical examination, there are 1 to 4 centimeter tense bullae, particularly over the flexural surfaces of the skin. A biopsy of one of the lesions is examined microscopically by direct immunofluorescence staining and shows a subepidermal bullae, with both IgG and C3 deposited linearly along the dermal epidermal junction. He is treated with topical corticosteroids, and a month later, the lesions are healed without scarring. Which of the following components of the skin has been targeted? Is it the hemidesmosome? Is it the keratinocyte cell membrane, nucleus, reticulin? This is relatively easy. I'm glad you guys are doing good. This was easy. I'll move on. Good job, R. Yes, this is going to be A. You guys are correct. This is a quick review I took from New World. Again, guys, an amazing resource for you to use. 10 out of 10, okay? I feel like I don't have to go over this. You guys actually did a really good job. So I'm going to review the pathological signs and symptoms, the pathological appearances mainly. Okay, Nasser, let's talk about how we can differentiate them clinically. So pemphigus vulgaris, the bullae are flaccid, meaning that if you rub it, they rupture extremely easily. You can find somebody, firstly, older age. They can appear in the middle age or the elderly. They come to you in the clinic, and you can also find bullae that have already been ruptured, okay? Vulgaris always, always, always involves the oral or the mucosa, okay? Sometimes the only finding could be the oral or the mucosal finding. It's a very silly mnemonic, but I'm going to tell it to you anyways. This is how I remember it. So vulgar is somebody who says a lot of bad words. And like you say bad words with your mouth. So that's how I remember it, like vulgaris, oral mucosa. Plus, I think of someone vulgar as someone who's like very like sensitive and easy to rupture. So I think of the bullae as easy to rupture because as soon as you touch it, it can rupture, okay? And that's why it has the positive Nikolsky sign. Our bullous pemphigus is tense. It's tense. No matter how hard you press it, it's not going to rupture on its own, okay? And usually there's no oral involvement, and it's mainly in the elderly, okay? I hope that's clear. Pemphigus, that's pretty low yield. I would say I wouldn't personally worry about that if I were you. I would say it's beyond your scope. All right, guys. Histologically, which is which? Which is which? It's a bit hard, but the image on the left kind of helps. So if you can't differentiate between them, check the image on the left. If you guys give up, I can explain it with you. So which is pemphigus vulgaris, which is pemphigus bullous? Just from the histological image. Good job, Nasser. Good job, R. Simon. Good job, Simon. It's quite obvious. Do you want me to explain it to you guys? Should I go over it real quick? It's quite clear. I feel like once you know the pathophysiology and the mechanism, it's quite clear. So as you can see over here, this is clearly bullous pemphigus because this is the epidermis and this is the dermis. And when we have our hemidesmosomes disrupted, as we can see, we have separation of the epidermis from the dermis. And it makes sense why it would be harder to rupture because there's a thicker layer of epidermis present. For pemphigus vulgaris, we can see that it's the intraepidermal affected. And as we can see here, the intraepidermal area has been disrupted, and hence why it's easier for the blisters to rupture. Guys, tell me which one is which here. Which is which? This is electron microscopy, immunofluorescence study, actually. Which is which? Good job. Yes, good job, guys. Amazing. Amazing. Perfect. Okay, moving on. You guys did really good. We have a 35-year-old man with an outbreak of a pruritic lesion over the extensor surfaces of the elbows and the knees during the past month. He has a history of malabsorption that requires him to eat a special diet, but he has no previous skin problems. On physical examination, the lesions are 0.4 to 0.7 centimeter vesicles. A 3 millimeter punch biopsy of one of the lesions was performed. Microscopic examination shows neutrophils at the tips of the dermal papillae and formation of small blisters caused by separation at the dermal-epidermal junction. Immunofluorescence studies show granular deposits of IgA localized at the tips of the dermal papillae. Laboratory shows serum anti-gliadin antibodies. That gives it away. Which is the most likely diagnosis? Is it bullous pemphigoid contact dermatitis, dermatitis herpetiformis, discoid lupus, or erythema multiforme? Good job, guys. Guys, how does erythema multiforme present? How does option E present? I feel it's more of a microbiology question, although there's a good job, R. Tayyib, what infection with what would you consider erythema multiforme? I know it's a bit of a micro question, but يعني for fun. Good job, period. Good job, Nasser. You're correct as well. Okay, you all got it correct. It is dermatitis herpetiformis. Guys, please don't, they might not give you that the tissue, the anti-gliadin is positive. So just know that this is how it appears as well, okay? It appears on the elbows, on the extensor surface, okay? And please know that there is granular deposits of IgA. Please know that it's IgA, specifically IgA, and that it's located at the tips of the dermal papillae. This is pretty high yield and it's pretty obvious, okay? Simin, the micro question, basically erythema multiforme causes a targetoid lesion. So it literally looks like a target. Most commonly, it's caused by Lyme's disease. So it's going to be by Borrelia. Okay, Lyme's disease causes the targetoid lesion. Yeah, Nasser, what's up? Most common. Yeah.
I'm sick of typing. That's erythema chronicum migrans for Lyme disease.
Yeah, but it can also cause erythema multiforme.
Oh,
Just
really?
know targetoid lesion, think of Lyme's disease.
Yeah.
But you're also correct. Okay, guys, we have a 77-year-old man that has a lesion on the right side of his face that enlarged slowly over the past 5 years. On examination, the 3-centimeter lesion has irregular borders, irregular brown to black pigmentation, and a central 2 millimeter raised blue-black nodule. The lesion is resected and microscopically shows a radial growth of large round malignant cells, some isolated and others in nests in the epidermis and superficial papillary dermis. The cells have prominent red nucleoli and dust-like cytoplasmic pigment. Which of the following mutated genes is most likely present in the skin of this man? Good job, period. Good job, Nasser. So what's his diagnosis here? Good job, R. Correct, it is melanoma. Melanoma, guys, in terms of metastasis, would you be worried about vertical growth or horizontal growth? Which one has the higher risk of metastasis? Good job, you guys. Good job. You're right, the answer is BRAF. We have a 65-year-old man that comes to the office due to 2 months of fatigue and persistent non-productive cough. He has a history of coronary artery disease and myocardial infarction. The patient has a 50-pack year smoking history. Vital signs are within normal limits. Chest radiograph reveals multiple lung lesions and hilar lymphadenopathy. Histopathology from one of the biopsied lung lesions is shown below. After staining with H&E, what is the diagnosis? Simon, good job. Good job, R. Good job, Simon. It's pretty clear from the histological image, guys. Oh, sorry, I did double C. Good job, MSA development. Good job. This was a pretty straightforward question. You guys did amazing. The answer is metastatic melanoma. This is how they appear, okay? What is this lesion called, guys? This lesion over here. What is it called? Good job, R. Is it malignant or is it pre-malignant? Good job. Good job, guys. This one here is superficial spreading. It's not pretty obvious, but I'll tell you guys. What is this one over here? Should I give you a hint? Good job, yes. And what's the one here in the bottom line? All of these. All of these. They're all of the same group. Good job, Simon. This is yeah, you're correct. You're correct. Yeah. Guys, out of all of these in the image here, which one has the highest risk of metastasis? Which one is the most malignant out of all of them? Which image? You're correct. It actually appears more in Black people. That's actually how Bob Marley died, by the way. He had acral lentiginous melanoma that ended up metastasizing, and that's how I remember it. But yeah, good job. Guys, this is nodular, and nodular usually spreads, good job, period. Nodular usually spreads vertically, and hence why it's the one with the highest metastatic potential, okay? We have a 75-year-old man with a slowly enlarging lesion similar to those in the figure, as you can see over here. His lesions are found in the trunk for the past 20 years. One of the lesions is excised, and microscopic examination shows sheets of lightly pigmented basaloid cells that are surrounded with keratin-filled cysts. These lesions are sharply demarcated from the surrounding epidermis. What is the most likely diagnosis? So you have both the gross appearance and the histological appearance. Correct, correct. Guys, how would basal cell carcinoma present? Good job. Yes, pearly, amazing, amazing. On the nose, good job. Does it present on the upper lip or the lower lip? Good job, Nasser. You guys were right. All of you got the correct answer. And It has a pretty good histology, honestly, seborrheic dermatitis. It's quite obvious what it is. So as you can see here, this is the keratin-filled cyst. It's very, very clear, okay? And this is our hyperkeratosis. And here we have our thickened epidermis. All of this is the epidermis. It's thickened, but the most pathognomic finding is the keratin-filled cyst, okay? And you guys are all correct in regards to BCC. We have a 66-year-old man that comes to the physician for evaluating rough skin on his forehead and the back of his hands. He tried applying different types of moisturizers with no improvement. He worked on his farm all his life. Physical examination shows 2 erythematous papules with gritty texture and central scale over the left temple and 3 similar lesions on the dorsum of his hand. This patient's skin lesion increased the risk of developing a skin condition characterized by which of the following on histopathology, guys? Increases the risk of developing which skin condition? So what does he have now? And what is he at increased risk of developing in the future? Period, you're correct. Simin, correct. That's a great diagnosis. So that means what disease will he develop later on? And what is the histological hallmark finding of that disease? R, why are we saying it's B? Why are we thinking it's horn cysts? Yes, period. You're right. Or dot. I don't know. Period or dot. Or think the most significant finding that this patient has is that he's been exposed to the sun his whole entire life. What does that predispose him to? And now he's complaining of a gritty sandpaper-like texture on his skin. This is pathognomic for a specific disease. Horn cyst is found in seborrheic dermatitis, which we discussed in the previous slide. This is our horn cyst over here, Simon. This is the horn cyst. But guys, our patient over here has actinic keratosis. It's a pre-malignant lesion and usually will lead to the development of squamous cell carcinoma. The most common pathognomic finding of squamous cell carcinoma is going to be the keratin pearls. You read keratin pearls, you know SCC is your answer, okay? So guys, this is the appearance of actinic keratosis. Again, they're going to describe it as the sandpaper-like appearance. It's going to feel rough, and no matter how much moisturizer they put, it's not going to help. Consider this in people who have a history of being exposed to the sun chronically. Also, SCC most commonly happens in the bottom lip. Again, this is another image of the keratin pearls over here. You can see it quite clearly, okay? We're reaching our last, this is actually our last question. Good job, guys, for making it all the way till the end. A 76-year-old man had a slowly enlarging nodule on his right eyelid for 4 years. On physical examination, there's a 0.3 centimeter pearly nodule on the upper eyelid near the lateral limbus of the right eye. The lesion is excised and multiple frozen sections are made during surgery to minimize the extent of resection and preserve the eyelid. The microscopic appearance is shown below. What is the diagnosis? Is it actinic keratosis, basal cell carcinoma, dermatofibroma, malignant melanoma, or the nevocellular nevus? Guys, why do we think it's B? R, good job. Guys, good job, good job. Simon, there's no pearls here. There's no pearls here. So guys, the diagnosis here is basal cell carcinoma. The reason why it's basal carcinoma and not squamous cell carcinoma is firstly the location. It's the upper eyelid and it's usually the bottom lip. And it's usually going to be described as dome-shaped. It's going to be pearly, okay? And typically it's also going to have telangiectasias. This is another high-yield histology finding, okay? So here's the histology finding of BCC. So as you can see, it appears as nests. These are the nests over here. When you zoom in on each of the nests, you can see that they're palisading. Palisading, it looks like they're all organized in a line. Is it clear, Simon? So you can see this is the palisade. It's all organized in a line, and this is the nest. This is the gross appearance. Please know the gross appearance because it's pretty obvious and it's pretty high yield. So you can see it's pearly, you can see it's dome shaped, and you can see that there are telangiectasias, okay? Most commonly, again, in the upper lip and the eyelid. The lower lip is going to be squamous cell carcinoma, okay? Guys, I'm so proud of you for making it this far. You all did an amazing job. I'm sure you guys are going to kill it. I tested you with things outside of pathology and you did an amazing job. If you guys have any questions, please don't feel shy. WhatsApp me. I'll answer you faster there. Email me, but please don't feel shy. My WhatsApp is open for you guys. Suggestions I have. Guys, Yani, please don't sleep on these suggestions. Wait, can we stop recording? Can we stop? And
Can you repeat the last part عشان the people who are gonna watch the recording?
guys, here is the QR code. Please leave me a review. But honestly, I'd love to hear directly from you as well. If you have any feedback for me, anything you would want me to change, or anything you'd want to hear more of or see more of, please WhatsApp me, email me. Don't feel shy. I'm here for you. Any questions you have, please ask me, okay? But yeah, it's the end of the session. I'm really proud of you guys. And I have no doubt that you're going to do amazing on your exam, inshallah.